We start then. Hello, everybody. Sorry for the delay. Sometimes these technical issues happen, so it has happened today. My name is Pedro Fernandez, and I'm the moderator of the session today. So good morning, good afternoon, good evening. You are connecting from many different countries around the world. So depending on the time that you have, you are very welcome to this event. In the past, we used to have these events live, in person, meeting with each other. But now, this is the new way we are having this kind of meetings. So I hope we enjoy. The good thing is that we are just now focused in the webinar, and we have been doing another things. For example, I've been cooking dinner for my family just before the webinar, and now here I am to be focused with all of you for 1 hour, and then we will follow our life later. In the past, we used to take a flight, go to some country, the day of the event, take a taxi or the metro, go in there. But the good thing of those times were that we had the opportunity to see each other, to talk to others. I was missing watching people going into the room, taking seats, talking to some of you, saying hello, exchanging experiences. So that's different, but we have to enjoy the new way, and we have to take the advantages of having this kind of relationships. So thank you very much for joining the webinar, A New Twist on GATT. I hope that you enjoy it, and you get good things for you, for your future practice. We have a mix of attendees here in this webinar because we have invited doctors who are interested in glaucoma, interested in GATT in particular, but we have also invited people from our distribution partners around the world. So if you don't mind, what we are going to do first is to ask you a question. You will see a question on your screen. So I would appreciate if you can answer so we know who is our audience today. Because I'm seeing now that we have at the moment 74 participants. So if you don't mind, and this is not the right one, but anyway, hold on a second. Can you, Gabriel, can you pop up the first question instead of this one? The first question that we have, this one. This is the correct one. Are you an ophthalmologist or an industry member? Okay, thank you for answering. I see that we have 20% ophthalmologists in the audience and 80% from our distribution partners. That's good to know, because our team members will need also to learn about the GATT procedure, and I hope that all you enjoy this session. So let me first introduce our speakers today. We have Dr. Fontana. He is Dr. Luigi Fontana. He is the director of the ophthalmology unit in Reggio Emilia in Italy. He's also a lecturer at the Bologna University in Italy, and he has experience, and he is specialized in anterior surgery, especially in corneal transplant, glaucoma, and cataract surgery. And he is the developer of the SharePoint GATT Suture that we are introducing today. Thank you for joining us, Dr. Fontana. And we have also Dr. David Grover. He's specialized in the management of complex glaucoma and cataract surgery. He has authored many peer-reviewed publications regarding new technology innovations in glaucoma surgery, and author of book chapters. He works at the Glaucoma Associates of Texas in Dallas in the US, and he is the inventor of the GATT technique that he will also explain us later. So this is all from my side as an introduction. The process will be that we will go with Dr. Grover first with a presentation. He will talk about the GATT procedure, how they came to the GATT technique, the patient selection. He has experience with the regular suture, with the sharp-point guide suture, and all the knowledge that he has regarding the technique that he invented. And then later I will take a few minutes to talk about the features of the sharp-point guide suture and how we developed this product. And then later, Dr. Fontana will explain. He has also a lot of experience with the GATT procedure. He will explain his learning curve, which is important for doctors trying to start with a new technique. And he will show us also a comparative study that he has recently published, comparing the GATT procedure with other glaucoma procedures. And he will talk also his experience with the sharp-point guide suture. So this is all for the introduction. So just another question before we go and I hand over to Dr. Grover. So Gabriel, if you don't mind, the second question: have you ever performed surgery using the GATT technique? Of course, this is a question for the surgeons joining us, not for the industry members that I'm sure that none of them have performed a GATT technique before. So I see that 90% of the audience, 25 doctors haven't, 26 now, have never performed GATT, and 9% of the audience, 3%, have performed GATT technique before. So this is the audience that we have. Good to know for the presenters. So Dr. Grover, all yours, I'll hand over to you.
Excellent. Well, Pedro, thank you for the kind introduction and for having us here today. It's always a pleasure and an honor to present with my friend and colleague, Dr. Fontana, who's just has always been a great thinker in the field and leader. And you know, Luigi and I go way back. We've met, I think, probably 7 years ago or 6 years ago, and he's been kind enough to also be a participant and instructor in our international GATT course. So he has a tremendous wealth of knowledge and experience. And you'll see with this presentation, he's going to demonstrate kind of a study that I think has been phenomenal with comparing GATT with trabeculectomy. But let's start off with just talking about the GATT procedure itself. The very first GATT procedure was done in October of 2011, and I was the first one in the world to do it with my partner and colleague, Dr. Ron Fellman. I'm not the inventor of the GATT. It was the synergy of the group of my entire partners at Glaucoma Associates at Texas, although Dr. Fellman and I were the first ones to ever perform it in the world. These are my disclosures, none of which I think are really pertinent to today. I'm going to start off with just a broader picture of my general surgical algorithm of glaucoma, a little background on trabeculotomy. I think it's important to take a perspective on where we're coming from, where we've been, and where we're going, as well as the description of the GATT surgery, and then go over some videos and patient selection and everything like that. So this is, you know, when I talk to my patients, I basically tell them I'm a fancy plumber of the eye, and I'm either going to open up their own drain or have to create a new drain. And what we're talking about here is when a patient has an intact outflow system, we're talking about surgeries that will help enhance the patient's own outflow pathway. And, trabeculotomy, it's not new. Trabeculotomy is, it traditionally was done from a conjunctival dissection underneath the scleral flap with a suture or a catheter, and it dates back to the 60s. Dr. Redmond Smith, one of the great thinkers of angle surgery, and he actually first described isolating Schlemm's canal ab externo through the conjunctiva, through little cut downs, passing a suture around, cutting down again and retrieving it and putting it back in and passing it on. And he was able to actually describe about 120, 150 degree trabeculotomy through this ab externo technique. And I love this picture right here, number 3, because it really shows what the angle looks like when you open it and you're having that anterior cleavage, and then that trabecular shelf falls down and you have confirmation that you've opened up the angle. And it just shows what a great thinker and observer that Dr. Smith was, Redmond Smith, in the 60s, because, we have now, fast forward 60, 70 years, I can now show the same exact thing he was describing in the 60s with in a patient that had GATT, where you have the anterior cleavage, and this is the trabecular shelf that falls down. But, talking about one of the other giants in the field, Morton Grant. So why trabeculotomy? Why are we even talking about the trabecular meshwork? Well, in the back in the 50s, Morton Grant, one of his landmark studies, demonstrated that about 3/4 of the resistance to outflow in primary open angle glaucoma is in the trabecular meshwork. Now, David Epstein redid those studies, and we think it's probably around 60%, 2/3 of the resistance to outflows in the trabecular meshwork. But regardless of the number, we know it's a vast majority of resistance to outflow. But what's the problem with this ab externo technique, right? It takes a lot of time, requires a lot of sutures, a conjunctival dissection, a scleral flap. You violate a whole quadrant, which could preclude you from success for subsequent surgeries if necessary, and it's relatively invasive. And so what we're seeing is this evolution of trabeculotomy in adults, from Redmond Smith to Harms, to the suture trabeculotomy underneath the flap, which was first described by my colleague and senior partner, Dr. Ron Feldman, back about 30 years ago with his mentor, John Lynn. And then we're seeing an evolution of this ab externo trabeculotomy with the catheter, and then ab interno with either a clear suture or a 5/0 proline suture. And now we're seeing it with the 6/0 twisted proline suture. But so this is not new. It's just a modification of a surgery that's been around for about 70 years. And it's a 360-degree ab interno trabeculotomy that we termed and coined that term, the GATT technique. And this was, I know we hired an artist to draw the key steps of the GATT procedure, making an initial goniotomy, and then going almost parallel and tangential to the back wall, passing the suture around 360 degrees and retrieving the end. And here's some still frames of the GATT surgery being done with a 5/0 proline suture with a blunted tip. You can see that blunted tip right there. You make a goniotomy, you press down on the back wall of Schlemm's canal. You want to approach the back wall of the angle as parallel as possible. And then this is the key step. If you look in D, and you'll see this in the next video, when you put the gonioprism on and you're passing it, turn it a little bit. Once the suture turns the corner, that's the most likely point that you're going to go through the back wall of Schlemm's canal and go in the suprachoroidal space. So once you know it's turned the corner, you're pretty much home free. And that's really, in my mind, the greatest risk of you going in the wrong direction. And then you pass it. After you've passed about 180 degrees, you're pushing this way and the suture has to go this way. So you're going to feel the resistance slowly increasing. And then right when you give up hope, you see the suture come around the corner, and then you reach over it and pull it. And so, here, let's talk about what it looks like to do a GATT procedure with this new twisted 6/0 proline suture that Dr. Luigi Fontana helped develop. And it comes, and this is exactly what it looks like. It's already has a nice little curve to it. I'm curving it, but it has a nice little end to it, so you're not having to do any prepping or any blunting at all. And it's ready to use upon opening, so it does increase the efficiency in the OR. And so let's look at a video. This was done just a couple weeks ago with a sharp point suture, a twisted 6/0 proline. And again, this is an infranasal incision, and I'm using an MVR blade. You can use a 23 gauge or a 25 gauge needle as well. It's key to really make sure you depress the back wall of Schlemm's canal. And then this is so important. Again, approaching it as parallel as possible. You don't want to go into the back wall, otherwise you're going to break through. And then you're going to see me kind of turn and make sure that I've turned the corner. And once I've turned the corner, you know, you're pretty much home free. And then you're just doing these slow and steady bites, and you want to make sure your chamber's formed the whole time. If it's not, come out and reform it. And you're going to see the resistance slowly increases as I'm coming around. And that's a good sign. If you're still going, and you don't feel that resistance, you're in the wrong place. It's popped out of the canal or it's in the suprachoroidal space. But right when you give up hope and you're wondering where the heck it is, you finally see it coming around. And then you want to retrieve over the suture, grab the tip, and this loop really makes it easy to grab. You want to make sure you're not grabbing any other structures inadvertently. And then I just hold it there and pull on the other aspect. Now, what I'm doing here, you're going to see some blanching. My partner and I also described the episcleral venous fluid wave, which is confirmation that this patient has an intact outflow system. So I'm going to pump up their eye with balanced salt solution, and you're going to see this blanching right here and almost 360 degrees. And I think it's a diagnostic and therapeutic maneuver where you're seeing that blanching, and you know without question that the angle is open and they have an intact outflow system. So was a question about what lens was I using? I'm using the Schwann-Jacob lens. I like that a lot. It's reusable. It's not disposable, so it keeps the cost down. You can autoclave it, and there's a left and a right-handed one. So I use the Schwann-Jacob one, and I can email the team the actual name, but I think later on in the presentation I have a list of everything that I use. This is a summary, just brief summary of all the papers that I know of on outcomes with GATT. So it's not just coming from our center, but it's been validated and shown across the world through different populations. And again, this is not a new surgery. It's a surgery that's been around for 60, 70 years. So we're seeing outcomes that are consistent with the outcomes that have been reported over the past 50 years out of Germany, out of Japan, on circumferential trabeculotomy. And GATT is going worldwide. This is not a map of COVID. Thankfully, this is a map of GATT, of the ripples that have been slowly expanding, which just, you know, gives me goosebumps and makes me so happy that that this technique is helping people around the world in a cost-effective way that have glaucoma. And so as far as I know, these are all the countries that I know it's being performed in. Anybody else on here that's doing it that hasn't a country listed, please let me know. I would love to add you to that list. So, you know, when do I use GATT? I think it's essential in mild to moderate stages of glaucoma with or without cataract surgery. I think it works extremely well in all forms of secondary open angle glaucoma with or without phaco. And patients that have real glaucoma, you're talking about the ocular hypertensives on latanoprost or have very mild glaucoma. These are the people that have a condition that I think has the potential of making them lose nerve fiber layer and lose nerve tissue and potentially lose vision. So the other thing, who are the best candidates in my mind? So like I said, mild to moderate POAG, this Avastin-induced glaucoma, the patients that are getting multiple anti-VEGF treatments, where I think the vehicle is clogging up the trabecular meshwork. They do really well. Pseudoexfoliation, which is such a hard disease to take care of, I don't get as scared anymore when I'm taking care of patients with pseudoexfoliation because GATT has just been such a great surgery to help them. The steroid-induced glaucoma, non-granulomatous uveitis that are actually controlled, traumatic glaucoma once the eye is quiet, angle recession, primary congenital glaucoma and juvenile open angle glaucoma, and then also newly diagnosed glaucoma. And so this is, you know, our 2-year data that we published showed that the cumulative proportion of failure in patients with advanced glaucoma with a mean deviation of worse than -15 was about 90% of 90%. So a failure rate of 90% in patients with advanced glaucoma. Now, these are patients in the United States that have had their eye abused by drops for, you know, 20, 30 years, which are different. You know, when I went and do these surgeries in other countries where patients present with advanced glaucoma, but they haven't been on drops forever. they've maybe been on a timolol for 3 months, their eyes behave in such a pristine way. I've had tremendous success in advanced glaucoma in other countries, in patients where their eyes haven't been been abused by drops for a long time. Who don't I do this in? So I don't do this in patients where I think they have an advanced a disease where their outflow system is just destroyed. Patients that need a drop a pressure of around 11 or 12 and they can't tolerate meds well. Patients that can't be taken off blood thinners, that can't have a limited activity for 2 weeks. I want them to sleep on their back with their head above their heart. And an unstable lens. I don't like to suture lenses if I don't have to. And if they have broad PAS or a lot of destruction of the angle, I don't like to do it in. This is my typical my post-op course. I'm very aggressive with steroids until their inflammation is controlled. The first go-to medication I use is pilocarpine, actually, depending on the pressure. I have them limit their activity for at least a week or two, as long as there's blood in the eye. And then, we know that outflow is not circumferential and is not equal around the entire eye, and that the nasal quadrant, specifically the infranasal quadrant, has the greatest potential for outflow capacity. And so say, for example, I had my right eye operated on. The classic thing to do is to tell the patient to sleep on their left side. But if they did that, then all the blood would layer in the nasal quadrant, which is the most important quadrant. So I always tell the patients to sleep on the side of surgery so the blood pulls away from the most important angle. I have a very low threshold. If they have a large layered hyphema, 3 millimeter, 4 millimeter hyphema, or a big blood clot that's blocking the pupil, after the first week, I take them back, keep them on steroids until the anterior chamber is quiet. And sometimes I leave them on steroids once a day and pilocarpine once a day for a couple months. And then I do slowly reintroduce drops if I need to, as pilocarpine, the first one, and then timolol, and then latanoprost once the eyes calm down. This will answer one of the questions that was out there. That was what gonio prism I use. I use the left gonio prism by Ocular. It's the trabectome one, and my microsurgical forceps. And then, so in conclusion, I think the GATT surgery is a novel, safe, minimally invasive conjunctival sparing surgery. The midterm success that we've reported and that have been reported throughout the world are similar to the data published for ab externo trabeculotomy. If you look at our 2-year data, the cumulative proportion of failure at 2 years ranges anywhere from 0.18 to 0.39, and the secondary groups and the combined phaco GATT groups tend to do better than the other groups. We do need longer follow-up, and we're working on publishing our 5-year data, our 6, 7, 8-year data. I would love to see more studies like what Dr. Fontana is going to present of prospective studies of GATT. And I think we have very good evidence that the suture GATT is equally effective to the catheter GATT. And I think the twisted suture GATT is a great addition in the evolution of GATT. It improves efficiency in the OR. And I think really when we talk about MIGS, especially MIGS, throughout the world, I think we need to have a discussion about cost-effective delivery of healthcare, and how to get the biggest bang for our buck. And I think the suture GATT has a tremendous implication for delivering cost-effective healthcare for glaucoma, surgical glaucoma around the world. For those who wish to learn GATT, once the world opens up again and the United States stops spreading this horrible virus, and we get a better rational scientific-based approach to how to control this, and we open up the world again, we've taught GATT, and Dr. Fontana thankfully has also been a key faculty of this course at the American Academy of Ophthalmology. It's a virtual course this year. I have an open door policy in my operating room. Anybody's always welcome. Please email me, and I'm happy to have anybody join me in my operating room. And I think I really enjoy these kind of peer-to-peer exchanges because it's so important for us to learn from each other. Especially these cost-effective deliveries of healthcare when there's not a potential for huge profit margins. So this is my GATT family, and in the middle is Dr. Fellman. He's really the mastermind, the genius behind the idea of coming up with GATT, and then he and I were the first ones to do it. But it was a synergy from the whole group. This is my email address. My YouTube channel has a bunch of other videos, but please don't hesitate to ask any questions. We want this to be as interactive as possible. And with that, I will stop sharing my screen so you guys can take control and turn it back over to Pedro.
Okay, thank you very much, Dr. Grover. Very interesting presentation. And I didn't mention at the beginning of my speech, but you have the Q&A in your screen. So if you have some questions for the doctors about their presentations, please write them in there, and we have a team of people selecting the best ones that I will ask them at the end of the presentation. So you can just write it for us. So briefly, before I hand over to Dr. Fontana, let me explain you how did we come to this suture. It was like, I think 3 years ago, not exactly, but I think that was 3 years ago at an AIO Congress. So Dr. Fontana came to our booth together with Luca Maranzana, the sales director of our Italian distributor. And I was there with Christine Di Martinis, our marketing director. So he wanted to share with us an idea, a suggestion that he had. He was performing GATT for some years, and with a regular suture that you have to prepare in the OR. So he was looking for something ready to use and able to perform a GATT procedure. And as we are manufacturers of sutures, he came to us, which I appreciate. And in fact, this is the way I like the relationships are with our distributors and with the doctors, because starting from those discussions, the new products, the innovations come to a product. So that's really good to have. So he explained us the GATT procedure, and he was looking for a ready-to-use product for this, and what he was doing at that moment. So then when that discussion finished, we came back with our team of engineers. We had some discussions, some ideas, and we realized that we had a similar product used for a different technique that may work for the GATT procedure. So I contacted Dr. Fontana, and I explained him, well, this is what we have. What do you think? And he said, well, I think that may work for GATT. So let's try it. So what I did is I booked a flight to Bologna, and then I rented a car to go to Reggio Emilia, which is like 1 hour drive from Bologna. And when I was going to exit the A1 highway, I saw the Calatrava Bridge, Il Ponte di Calatrava, which is just at the exit of the highway. Let me show you this bridge, because it was a sign for me. I was just before going out of the highway to Reggio Emilia, I was watching a representation of an anterior chamber with the Schlems canal on the right and the left. Not exactly, of course, but I was saying to myself, wow, this is going to work for sure. This is going to work tomorrow. So this is what we did. The day after, I went to the OR with Dr. Fontana, and he performed a few cases. It worked, the product that we bring to him, and I left him some more samples, some more products. He kept trying, and he uses some more other products. And in the end, we said, okay, it's working. So then it was our part from a regulatory perspective and from a production perspective to fulfill all the documents and do all the paperwork to have the product that we are launching today, the SharpPoint GATT suture that we are introducing to you today. So very briefly, let me explain you what the features of the suture are. As I told you, the suture is, as Dr. Grover told you, is a twisted suture that is packaged in a racetrack, ready to use. So you just need to peel the label, grasp the suture with your forceps, and it's completely ready to use. It's an 8 centimeter twisted suture, so it's a perfect length to introduce it into the Schlems canal and have also the right length to manipulate it properly, with a blanket, a stainless steel blanket at the back part, which only keeps the suture twisted all the time. So below are pictures of the product, real pictures of the product. And Dr. Fontana will show you later more about this. Just for me to finish, I think that the GATT suture, the SharpPoint GATT sutures have 4 advantages. One is that it's a ready-to-use product, so you just need to open the box and use it for the procedure. Second, the rounded tip is always the same. You always have the same tip in the product, so you don't have, when you are preparing a regular suture and heating it, you maybe get different sizes. In this case, it's always the same. The spiral structure makes that the evolution, the move of the suture works well. And the fourth advantage is that it's an economical and an effective solution for glaucoma surgery. So that's all from my side. I hand over to you, Dr. Fontana. It's your turn.
Thank you very much, Pedro. Thank you for your very kind introduction, very generous introduction. And it's an honor for me to follow to Davinder Grover, who is an awesome surgeon and teacher. And for me, it was very inspiring meeting him and learning from him about the GATT procedure. And here are some of the recent work and the history behind my experience with the GATT procedure that I started probably in 2014, since after I had the honor and the pleasure to meet Davinder. I must say that I invited Davinder a couple of times to Italy, and the first time he couldn't make it because he broke his Achilles tendon while playing basketball. He's also an excellent basketball player, and so he couldn't make it. And the second time I invited him over, then the the COVID pandemic infection started, and I think that, Davinder, this is a bit of an excess of an excuse for not coming to Italy. I mean, it's you shouldn't have done all this, you know, for not coming over to Italy. It's next time, you know, you just tell me I cannot make it. It's that's good enough. Okay. Anyway, fantastic teacher, very humble person, very easy to get along. And I do invite everybody to try to get in contact with him if you want to learn about this technique, because he's really terrific. It did change my life in terms of what I do in my practice for glaucoma surgery. And my patients are very happy with it. And it's one of the most revolutionary techniques that I embark on recently. And I hope that to see more advancements with this technique in the future. Nevertheless, when you approach a new technique, there are phases you have to go through. And of course, you know, there are up and downs, and sometimes, particularly at the beginning, you may have a good run of cases where you can incannulate a Schlemm canal and do a complete 360-degree trabeculotomy. But then after sometimes some problems start, very often because you try also to tackle more difficult cases, and then sometimes, you know, you do not achieve the same initial success, and then you may get a bit depressed. But eventually, then there is a certain point where everything changes and you start getting consistent with your results and with your technique. And then is when you can say that you master the technique itself. Now, what are the difficulties with the learning GATT? Of course, I think that one of the most difficult things is the fact that you have to adapt to a technique where you have to use a gonioscope, you have to use a particular position with a microscope with the patient head in order to visualize the trabecular meshwork. And you have to recognize the trabecular meshwork. Unfortunately, not very many people now use the gonioscope anymore, and this is a shame. And you have to be able to make a good size of goniotomy in depth and length. And of course, you have to incannulate a Schlemm canal. And as Davinder said, you have to avoid the suprachoroidal space. Now, this is a position of the microscope which has to be tilted about 30 degrees, and then you have to tilt the patient's head in the same direction as a microscope, sitting on the temporal side of the patient. And this position is relatively awkward, particularly in the beginning. You have to keep your arms straight in order to hold on the gonioscopy lens, and learning to use both hands at the same time as you're doing for phaco emulsification in a way. This is something which is completely new for a traditional glaucoma surgeon who is just adapted to use a microscope in a straightforward position doing trabeculectomy. What are the indications for this procedure? Mostly is something that Davinder has already said. I think that pseudoexfoliation is certainly the most rewarding of the indication, and certainly it does work also in pediatric patients who we know are very difficult to deal with. Then there are some question marks where you can use and adopt this procedure, for instance, in closed angle glaucoma, and I believe it's so. And of course, you cannot use it in patients who cannot suspend anticoagulants, otherwise the bleeding would be too much. So choosing the right patient at the beginning, I think, is fundamental. I will start choosing a patient who is already pseudophakic with a deep AC, so in order to reduce the risk of lens touch during surgery. Patients who have a complete aerocapsular diaphragm in order to avoid blood to reach the posterior segment and the vitreous, otherwise it will remain there for quite a long time. Avoiding patients who have an AC IOL, again for the same reasons as for the lens touch. Of course, the cornea must be pristine, clear, because otherwise you won't be able to see the angle. No previous filtration surgery at the beginning, and no anticoagulant therapy. Now, this is my personal learning curve that I recently published with the GATT procedure, encompassing my very, very early cases with the GATT procedure. And I just learned the procedure by myself, watching videos, watching Davinder Grover and other videos. And so I never had anybody sitting next to me who was already experienced with this procedure itself. And you can see that in the first early 20 cases, I could not circumnavigate the Schlemm canal with my device in every case, probably at the beginning in less than half of the cases. But then eventually after 20 cases, I became more consistent and more skillful with the technique. And as you can see in the last 20-40 cases, I managed to achieve a complete 360 trabeculotomy almost in every single case. So this is something that has to be mastered in a way regarding the position of the patient and the position of the surgeon and the microscope. Now, what happens if you do not get a complete 360-degree trabeculotomy? As Davinder said, the most important part for the aqueous reabsorption in the angle is the nasal one. And of course, when you start the procedure in cannulating the Schlemm canal from the nasal side, as most of the people do, you are pretty sure that you will be able to open the Schlemm canal right in the nasal side, which is the side of your initial approach. And this probably helps on achieving a successful lowering of intraocular pressure. As you can see here in orange, a patient where I could not complete a 360-degree trabeculotomy, still they have achieved a mean intraocular pressure of 16 millimeter of mercury, whereas patient where I managed to achieve a larger 360-degree trabeculotomy, the pressure was around 15 millimeter of mercury. So the difference between the two is not huge, but there is a difference. So if you do not achieve a 360-degree trabeculotomy, it's not a major drama, but if you can, the results are better. Now, what is the lowering, the percentage of IOP lowering reported in the literature. Here are the main studies reported in the literature, enclosing a relative number of patients. And you can see that the intraocular pressure reduction is at the level of 40 to 50%, which is in quite a variety of glaucoma population. This is a study I was referring to, comparing trabeculectomy with mitomycin C to GATT at 18-month follow-up. You can see that the intraocular pressure reduction is greater, of course, as expected after trabeculectomy. But in GATT, the intraocular pressure reduction was still in the level of the mid-teens, whereas after mitomycin C is expected, it was in the low teens. As for percentage of intraocular pressure reduction, again, following trabeculectomy with mitomycin C, intraocular pressure reduction was 56%, but after GATT, it was a good 42% at 18-month follow-up. Now, in regards of the lens status, combining phacoemulsification to GATT procedure, it does allow to lower the intraocular pressure a bit more than when you approach a patient who is already pseudophakic or is phakic. And this is, of course, an advantage of being able of combining phacoemulsification to GATT procedure, as you can use the same approach, the same incisions for both procedure, without having to do other approaches, as probably most of the people do when they perform phacoemulsification combined to trabeculectomy. Now, this is a video about the use of the sharp point twisted suture for GATT. Let's see if I started. Here it is. And basically, the approach is similar to the one that Davinder just showed before. Here's a ready-to-use suture. And again, the surgeon is sitting on the temporal side, and he has to make a temporal incision, which I do not make it too limbal in order to avoid bleeding from the limbal vessels. Don't know why it's skipped. Sorry about that. Try to start it over again. Again, the suture is ready to use, and you don't need so many other instruments in your table. The patient, the surgeon is sitting on the temporal side, a limbal incision, and I make a paracentesis about 90 degrees away from my temporal incision, and these are the only two incisions that you have to make. As I said, avoid limbal vessels in order to reduce the bleeding. Then it may also go underneath your gonioscopy lens, and I use a 2.2 calibrated knife, but you can use also 1.5 calibrated knife if you have it. I fill the anterior chamber with Helon GV, and then I introduce my suture, which is again is a sharp point twisted suture, and then I tilt the microscope, as you can see, about 30 degrees, and then I use my gonioscopy lens, which is again, this is a heel lens, but Swan-Jacob lens, it works as well. I do use an MVR blade, but you can use also a needle for doing your goniotomy, initial goniotomy, which has to be on the nasal side, as you can see, about 1 to 2 millimeter. I expose the Schlemm canal by decompressing my goniotomy. Here is the position of the hands, which are in a kind of straight hands. I grasp the suture right close to the tip, and I introduce it into the Schlemm canal. As you can see, I can follow the suture for a while as he is progressing inside the Schlemm canal. And this is very important because, as Davinder said, you can be sure that the suture is in the right position. Then I advance the suture progressively, and you do feel an increase in resistance. And then after some time, you do see the tip of the suture coming in your field of view, and then you can grasp it with your forceps. These are MST forceps, and then I pull the two hands of the suture, and here you have it. So the absolutely normal complication that you have in every single case is hyphema, which is very frequent, and this is something that it comes from the fact that the Schlemm canal itself and the trabecular meshwork are vascularized, and so of course you do get some bleeding from the trabecular meshwork and Schlemm canal. You may have pressure spikes, which are relatively rare, and this may be due to viscoelastic remaining inside the eye, or from blood clots that may develop sometimes after the procedure. Very rarely you may have early failure, which are probably due to the fact that the collector channels are not patent, or maybe they also are maybe due to the use of topical steroids after surgery. And so this is something you have to be aware of. In conclusion, according to my experience, GATT effectively lower the intraocular pressure at least at 2 years after surgery, reducing significantly the number of medication. There is a very high safety profile with this procedure, as the complications that are connected with this procedure are very few. Bleeding, as I said, could be one. In very few cases, you may have to wash out the blood clots inside the anterior chamber. But otherwise, in the long term, I haven't seen relevant complication with this procedure. Again, it's a conjunctival sparing technique, which of course it does in a way leave you space for a subsequent filtration surgery, whether it could be trabeculectomy or an implant of a tube, without reducing possibly the risk of failure due to the fact that the conjunctiva has been already used for other procedures from before. So in a way, I do use this procedure in very many cases as a first approach, as a first surgical approach. And in some cases, such as tooth exfoliation, I do use it also early on when the patient is not already on maximum full therapy, as we know that this procedure works very well in this patient. Thank you very much for your attention. Thank you for having me. And I really would like to thank again Davinda for having introduced me to this magnificent field. Thank you.
Well, thank you very much, Dr. Fontana, for your presentation. So we have some questions. I see that some of them have been already answered, but why not, just in case that the audience haven't read it. I have one of them here. Would like to know the difference between a small tube, iStent, cut apart with a hook, or a total part with GATT. How can all those three options good for same patients?
Davinder, you have experience with all of them, I guess.
You are on mute. You are on mute. Ah, you can't. Can somebody unmute Dr. Grover, please? Sorry.
All right,
Yes.
thank you. Yeah, I said the host could only unmute me. I think my wife wishes she had that button. Yeah, no, I think what's, and this is even a whole lecture that I give, but I think what's nice is we can kind of tailor the stage of disease to the patient and the patient's lifestyle and what you need. So, I kind of think of them as a spectrum. So if I want, those patients that are ocular hypertensives or have very well-controlled pressure on one drop, those are the ones I really think an iStent would work well with, or a Hydrus. And it's not even just what I think, it's even if you look back at the pivotal trials that demonstrated them, you saw a 1 to 2 millimeter mercury benefit from iStent. about a 1 millimeter mercury compared to phaco alone. Hydrous is 2 to 3. When you look back at the Cook dual blade goniotomy, you're getting about a a 2 to 4 millimeter mercury benefit with maybe a decrease in need of one medication. And then as Luigi summarized so nicely, when you look at all the GATT data around, you're getting 40 to 50% lowering in pressure, which is usually around 8 to 10, depending on the patient, with at least a drop of 1 to 2, if not 3 medications. So, would I do a GATT surgery in an ocular hypertensive on latanoprost? No. No. Would I do an eye stent in a patient on, 4 meds and a pressure of 25 and they need a pressure of 17? No. So, I think the general rule is that the more of the angle you access, the more you open up, the better pressure lowering you get. And that's kind of my general approach to how I treat these patients.
Okay. And another question that I would ask, I know that you, Dr. Fontana, have talked about that already, but what would you recommend, like the key things for a surgeon that is not using a gonio lens at the moment? What would you recommend him? Because doctors using a gonio lens already, they have a learning curve, but what about those ones that haven't used a gonio lens yet?
Well, I think the easy way to try is in a regular phacoemulsification setup and list. What I would do is to try to adapt yourself to the use of the gonio lens by before you start, performing a phacoemulsification procedure, before you have incise the cornea. What I would do is just to rest the gonio lens on the eye and tilt the microscope and try to get a view of the angle and try to adapt to this different position. And once you've done it 2 or 3 times, then you're ready to start, using the gonio lens together with your other device for starting doing GATT procedure. It's not so difficult. I know that many people are in a way put off by the awkward position of the microscope and the awkward position of the surgeon. But at the end of the day, we are all used to doing phacoemulsification sitting on a temporal side in most of the cases. And so I think it doesn't take much to try to use the gonio lens for the first case. It's not that difficult at all.
Okay, thanks. And another question for Dr. Grover. I've heard several times that this kind of procedure is for countries probably where they have more restrictions to get more expensive devices, but you are in the US, which is not one of those countries, and you are using it. What do you think about this statement?
Yeah, that's a great question. I think regardless of where you are and what country you're in and what healthcare system you're restricted to, I think we need to be good global citizens and be conscientious and conscious of the cost implications for our decisions. And nothing is free. Even that the U.S. is, you think there's still, I think one thing this pandemic has taught us is that it's been a harsh reality check for a lot of people in the United States. It's the first time they've ever experienced scarcity or rarity, or the fact that there's not something available. And I think it's been it's been instructive, hopefully, to a lot of us to realize that, just because it doesn't cost me any money directly to use $1,000 device, it still costs society to use that device. And so probably about 8 years ago, I switched to doing the suture. Because I think it's I think it's better. I think it's just as good, if not better. When I've taught it around the world, some of my colleagues have told me that they actually like the suture better than the catheter, because the catheter can kink, and there's some issues with that, and it's very expensive. It's cost prohibitive. So well, I think some people have that mentality in the United States that there's no it doesn't mean anything if I can use $1,000, $2,000 device, and just because it doesn't come out of my pocket, it doesn't hurt me. That's just not true. You know, what happens in the healthcare system in the United States is that reimbursement gets cut. So physicians, we don't speak with one voice, especially in the United States. We can't lobby our politicians the way these large multi-billion-dollar companies do. And so when it comes to cutting cost-cutting measures, you know, they can either choose to cut reimbursement for an instrument, or they can choose to cut a doctor's reimbursement for a surgery, because it all comes out of the same pot. And the way it has been done, and the way it always is being done, is they're cutting my reimbursement for cataract surgery. They're cutting my reimbursement for trabeculectomy. They're not cutting a multi-billion-dollar company's reimbursement for the device that they're selling. So, so I do think that even if we think we live in the land of excess and lack of no scarcity, I think that's just not real. And what's going to happen, as it has in other countries, is regulators, if we're showing that we're not able to regulate ourselves, regulators are going to start regulating us and say, okay, you're spending $1,000 to lower the pressure by 1 millimeter of mercury, and you can spend $4 and lower the pressure by 8 millimeters of mercury. Show me the justification that you're spending that much money and why. And that's coming if we don't regulate ourselves. So so I think we have a moral and an obligation to ourselves and to our patients to provide the best quality care in a way that's safe, but also cost effective.
Something to add, Dr. Fontana, from the Italian European perspective?
Okay, well, we have less resources than probably the surgeons in the United States. So for us, you know, in a way, saving that amount of money that you spend for a catheter is probably more important. Of course, it depends on how many cases you do a month. I mean, I'm sure that Davinder and Associates, Glaucoma Associates in Texas, they do perform a very relevant number of glaucoma procedures every day, every week. And so for them, you know, saving that amount of money is even more significant. For a beginner surgeon, probably just approaching few cases a year, using more expensive devices could be, in a way, still, you know, feasible for them. And in a way, what I suggest is to try to learn the procedure using both techniques, the catheter and the suture. And of course, you know, the catheter allows you to follow the path of the catheter itself, you know, along the 360 degree, and so you can, in a way, be reassured of the position of the device inside the Schlenk canal. With the suture, you have to be a bit more, say, acquainted with the procedure itself, a bit more skillful, a bit more experienced with that in order to achieve the same results. But saving money at the end of the day is something that is an obligation for every one of us working in the NHS particularly.
I think, Luigi, you bring up a good point. I did a 6-year-old girl that had a spectrum of Sturge-Weber, but also I thought some component of just primary congenital glaucoma and angiodysgenesis. And those patients are very, very likely to have an abnormal collector system and a Schlemm's canal, and you're very likely to go in the suprachoroidal space. So still, when I'm doing my babies that have glaucoma, when I suspect that they're likely going to have an abnormal angle, I will have the catheter ready because I think it is nice to know, especially when you have a high chance of an abnormal angle, for the catheter to be available and to use.
Okay, thank you very much, both of you, Dr. Grover, Dr. Fontana. Thank you very much, everyone attending this session. It's 8:07 here in Madrid, and your time in your places. So we have spent 1 hour talking about that. We really appreciate very much your attendance. So thank you, and I hope you see you soon in person. But if that's not the case soon, maybe another time here on the line. Thank you very much, everybody. Bye.
Thank you.
Thanks,
Thank you.
Thank you.
Bye.
Take care.